Hi everyone and welcome to ECG A Day. In this particular video we're going to go through a series of tracings from the same patient. I thought they're all excellent at demonstrating learning points, so I kept them all, and I hope you enjoy them and learn a lot from them. So having said that, let's get started.
So this is the initial rhythm strip that was sent for a consultation. So you're welcome to pause this video and come up with a differential diagnosis for this tracing. This is a 12-lead ECG that was performed shortly after this rhythm was discovered on telemetry. Shortly after the tachycardia started, the telemetry nurse noted that the rhythm has changed, that the QRSs look different, and so they got a 12-lead rhythm strip. This is a few minutes after the initial tracings were recorded. And this is the last rhythm strip that shows the termination. So here, try to come up with a differential diagnosis or a single diagnosis if you have enough information, and anything else you can do to confirm the diagnosis. So now at this point, we'll go back to the first tracing and we'll go through it in detail. If you watch any of my videos, I always have the same approach to ECG tracings. So the first step is to describe what I'm looking at. And what I'm looking at here is a single lead tracing. So we have a single lead right here. Then in the middle, we have an SpO2 sensor tracing, and at the bottom, we have respirations. And we actually have a time here on this tracing, and whenever it's a single lead, it's generally a time, and it's close to noon, so it's not at nighttime, so it's not terribly helpful in this case. The second step is to identify the problem. And in this problem, this is a tachycardia problem, and in particular, this is a wide complex tachycardia problem. And the third step is to formulate a differential diagnosis. So differential diagnosis with any wide complex tachycardia is always the same. It's always VT, SVT with aberrancy, pre-excitation, pacing, and artifact. I don't see any pacing spikes here, so I think we can safely remove that from the differential. I mean, it's fairly uncommon for a pacemaker to be pacing this fast out of nowhere, and I don't see any pacing certainly when this rhythm terminates. I don't think this is artifact because I have an SpO2 tracing here, and I can see that there is an upstroke on the SpO2 tracing for each QRS complex. So I know that these are real QRS complexes. This is very unlikely to be artifact. Pre-excitation is quite rare, and we actually have a sinus beat here which does not look pre-excited. So overall, we put pre-excitation at the very bottom of our differential diagnosis list. So what we have left is VT and SVT with aberrancy. So to distinguish the two, we need to use a series of tools available to us. These include the Qrs Morphology in the tachycardia and in sinus. We have a PVC here with a nice retrogradely conducted P wave right there. And we have the termination of the tachycardia right here. Overall, Qrs Morphology is hard to distinguish in a single lead tracing. However, we can compare it to sinus and we can say it looks different. And this could still be a rate-related bundle branch block, or it could be VT. And certainly the initial forces of the QRS here are quite sharp, which would be consistent with both VT and with a bundle branch block, because if you recall in bundle branch blocks, the contralateral, the functioning bundle still leads to initial rapid forces in QRS depolarization. The initial deflection of the QRS is upgoing, the same as sinus. So if this was a bundle branch block, this would most likely be a right bundle branch block. Next, let's look at the PVC. We can see that this PVC looks nothing like the QRS in a tachycardia. Certainly, if the PVC looks identical to the tachycardia, then you would just presume that the mechanism of the tachycardia is ventricular. Next, let's look at the AV relationship. Looking at this rhythm strip, I see that there's initial fast forces the QRS, and there's terminal slow forces in each QRS. And there's also this high frequency stuff before this high frequency signal just before the initiation of the QRS, and I see it in every single cycle. So this is a good candidate P wave. I'm not 100% certain that it is a P wave, but it certainly looks like it's the P wave because it's high frequency and it's outside of the bounds of the QRS. However, it's not terribly helpful here because we see the signal in each cycle, and it's in exactly the same point in each cycle. And you can see here at the end, these are the candidate P waves, and it looks to be ending with a candidate P wave. So overall, this is a one-to-one associated AV relationship, which is not helpful to distinguishing VT versus SVT with aberrancy, because there's a lot of one-to-one AV associated SVTs, basically all of them, and VT can also be retrogradely conducting and conduct to the atria in a one-to-one fashion. And terminating like this is a very clean termination. Terminating on a suspected P wave also does not help, because a lot of SVTs can terminate with an atrial depolarization and block in the AV node, except perhaps atrial tachycardia. And same with ventricular tachycardia, it can terminate and the last V conducts to the atrium. Okay, so this would be compatible with a ventricular tachycardia. So overall, I think the only thing we've ruled out is an atrial tachycardia, but VT and all the SVTs are still on the differential diagnosis list. How did I know that the Qrs morphology on the last slide with a single lead tracing resembled a right bundle branch block? Well, the key is to compare it to sinus rhythm. During normal sinus rhythm without any bundle branch blocks, this first part of the heart to activate is the septum, and it activates via the left bundle branch block septal connection. And the septum is the first part to activate, and it activates in a left to right fashion. When you have a right bundle branch block, the first part of the QRS actually doesn't change, because the left bundle is still functioning and is still able to activate the septum in the left to right fashion. So the initial forces of the QRS generally don't change with the right bundle branch block. For example, look at this QRS. This is a right bundle branch block in the lateral leads. It looks fairly normal, except for this terminal S wave, which stretched out a little. This represents slow RV activation. Contrast that with a left bundle branch block, where the axis, the initial activation forces of the QRS, completely change because the activation of the heart is very unnatural. When I look at this 12 lead ECG, the first thing on my mind is this the same arrhythmia or a different one? Comparing the rate of the arrhythmia on a single lead tracing and the rate on this arrhythmia, it's very evident to me that the cycle lengths are the same, and you can measure it yourself to confirm this. If the two arrhythmias have the same cycle length, the chances are they're the same mechanism. So approaching this ECG, this is a wide complex tachycardia, which we narrowed down to VT and SVT with a bundle branch block. And looking at this Qrs morphology, which is the extra tool given to us on this tracing, I see that this is a very good left bundle branch block. It's generally positive in the lateral leads and AVL, and I see it's got a very fast downstroke, which is very typical of a bundle branch block. It's not slurred at all. There's no notching on the downstroke of the QRS in D1 and V2, which would be very unusual in a left bundle branch block and would highly suggest VT. Brugada has figured this part out and has actually included it on in his algorithm. Even though we don't use the Brugada algorithm, I still think it's important to draw some wisdom from it, because Dr. Brugada has done the footwork to determine what's typical and atypical for a bundle branch block. Here I also see that little high frequency deflection, that little signal before each QRS. I still see it in these leads here, and this is very convincing for a P wave because it's outside of the QRS bounds. If I put a line on QRS onset all the way down this tracing here, down to here, I can see that this is where the QRS initiates, right? So I can see this is outside of the bounds of the QRS. And I'm fairly convinced it's a P wave. However, this P wave, if it is a P wave, is a one-to-one associated with all the QRSs, so it's generally not helpful because VT and SVT can have this. So overall, what strikes me as interesting that this is a left bundle branch type aberration, or bundle branch type QRS. And on the previous strip, we saw a right bundle branch type QRS.
Having both left and right bundle branch type QRSs, it's very unusual for VT. How could a single VT mechanism be exiting from the right ventricle and from the left ventricle? It's almost impossible. So overall, VT is eliminated, and the diagnosis is SVT, because SVTs very commonly can have left and right bundle branch block aberrancy. This is another tracing recorded shortly after. And as you can see, this is the same cycle length, so it's the same tachycardia. However, the Qrs morphology is a fairly good right bundle branch block, right? It's got an R, S, R prime in V1, which is very typical. It's got this slow S wave in the lateral leads, and the first part of the QRS is very sharp, which is very typical of a right bundle branch block. So this helps confirm that we have an SVT with left and right bundle branch block aberrancy. And this last tracing here shows us a narrow complex tachycardia with the same cycle length. So this confirms the diagnosis of SVT, and this is a narrow complex tachycardia problem now. And I can't see P waves very well in this tracing. We do have the termination, but it looks like it terminates the same way as before, so I don't have any additional information available to me. So all we could say at this point, that this is an SVT with occasional left and right bundle branch blocks. In this particular case, the patient gave adenosine at the time that the patient had a tachycardia with a right bundle branch type QRS. And as you can see, this is a clean termination when adenosine took effect. There's no PAC or PVC that broke the tachycardia. It broke on its own once the adenosine has taken effect and has blocked the AV node. So this is an AV node dependent tachycardia. So the two that are AV node dependent are AV NRT and AV RT. And those are the top of the differential. There's not much more information that can be gained from the rest of this tracing. You see that there is progressive AV block that develops. There's some PVCs, and then there's an escape here that originates from a left bundle. That's why it looks like a right bundle branch type escape QRS. All right, thank you for bearing with me through all of these tracings. I want to take a moment to summarize the key learning points. So if the patient has more than one tachycardia and they're the same cycle lengths, chances are they're probably the same mechanism. The second learning point was if the patient has a tachycardia with a left bundle branch type and a right bundle branch type QRSs, then it's probably SVT with different aberration patterns. Because why would a VT exit in the right ventricle and in the left ventricle? It doesn't make a whole lot of sense. And the third learning point is we discussed a number of ways to identify bundle branch blocks on single lead tracings. That can be quite helpful when you have a lot of extra wide beats, which we'll talk about in the other videos. And the last learning point is that if you identify P waves and you find they're 1-to-1 AV associated, that's not terribly helpful because both VT and various SVT mechanisms can present this way. Great, so I hope you learned a lot, and have a great day.